right, it looks like it is right on the hour, and I want to welcome you into our session. It's no small matter addressing children and youth suicide and other behavioral health crises with developmentally appropriate crisis continuum services and supports. We are so excited to have you here. We're grateful for your time, very grateful for the folks that you see on the screen for their time, and I will introduce them in a second. First of all, I need to remind you of just a few things. I need to remind you of our commitment to maintaining a safe and accountable space. If you experience any issues or need assistance, please reach out to me by sending me a direct message found at the top right corner of the event. To walk you through the tools in this session, I'd like to draw your attention to the vertical bar featuring several icons on the right side of your screen. If your event feed is open, so for the whole event, it's going to be hiding your vertical bar for this session. So please close the event feed by clicking on the X in the upper right corner of the event feed. The event feed is also the chat box for the whole event. So if you want to ask questions for this event, then you need to close that. When you close that, you'll see a vertical bar and there's a Q&A icon. This is the place to ask our lovely presenters questions. You can also vote for questions if you're interested in hearing the answer to the question, and that will help them triage the questions and answer them. There's also an icon of people, including the participants in this session, and you'll see two papers stacked on top of each other. These are all the resources from the presenter, including the slide deck for this session. So we can help with questions. First of all, we are going to have questions at the end. We're going to have the presenters give their presentations, and we're going to keep them for the end so you can vote along the way. Again, that's the third icon from the top with the Q&A on it. If for any reason during this session you need to step away, take a break, debrief, decompress, please feel free to do that. We have a wellness room that's open. You can enter the wellness room by clicking on the wellness room button at the top left side of the event navigation bar, and a member of our team is there to meet you. So the resources, if you close your event window, the resources icon should be the pages. One page on top of another. It's the 1, 2, 3, 4, 5, 6, 7 icon down on the icons on the right-hand side. So I'm going to take a moment to introduce our speakers. First of all, we have Jill Mays, who is the Division Director for the Crisis Transformation for the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA. She currently leads this evolutionary and collaborative work of pillars 2, someone to respond, and 3, a safe place to help, of the 988 Behavioral Health Crisis Continuum. Before coming to SAMHSA, Ms. Mays served as a Director of Office of Behavioral Health Prevention and Federal Grants at the Georgia Department of Behavioral Health and Developmental Disabilities, where she most recently oversaw all substance misuse prevention, suicide prevention, mental health promotion, and behavioral health equity strategies. She had a big job. And served as principal investigator for the agency's multi-million-dollar portfolio of federal grants, including this work, 988 and CCBHC grants, as planner for the mental health block grant. Additionally, as assistant director of the Office of Adult Mental Health at DVHDD in Georgia, she was the project officer for crisis services. Mrs. Mays previously coordinated operation of SAMHSA's Disaster Distress Helpline, Core Regional Call Center in Atlanta, serving FEMA Regions 3 and 4. She is a licensed professional counselor with over 30 years of experience in behavioral health, and is a person with mental health lived experience. I'd also like to introduce you to Dr. Belina Shaw. She is a senior medical advisor within the Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration, SAMHSA. She's triple board certified in areas of child, adolescent, and adult psychiatry and addiction medicine, as recognized as a fellow of both the American Psychiatric Association and the American Society of Addiction Medicine. She received her bachelor's degree in psychology from Yale, doctorate of medicine from the University of Pittsburgh School of Medicine, and master's degree in public health from the Bloomberg Johns Hopkins School of Public Health, where she was a Bloomberg American Health Initiative Fellow in the Addiction and Overdose Focus Area. Dr. Shaw did her general adult and child adolescent psychiatry training at the University of Maryland Shepherd Pratt Residency Training Program. Prior to working at SAMHSA, she served as the medical director of behavioral health division of Prince George's County Health Department. At SAMHSA, some of her areas of focus include serving as a liaison to the 988 and Behavioral Health Crisis Coordinating Office, co-leading the Black Youth Suicide Prevention Initiative, directing the Interdepartmental Serious Mental Health Coordinating Committee, and assisting the center activities concerning the behavioral health impacts of long COVID. It is my very great privilege and honor to introduce both of these women to you. They have so much to offer from the 988 Center. So please take it away.
Good afternoon, everyone. So I'm going to attempt to share my screen. All right, can you all see the slides?
Now yep,
No?
I think we
Yeah.
can. Nope, we're good. We're good.
Okay,
Thanks, Jill.
wonderful. So I can't see you all. I can only see the slides. But after the presentation, well, we'll hold off to the end for Q&A, but just know that I can't see you all, but I wish that I could. I'm so excited to be here with you all today. As Liz mentioned, when I was director of federal grants at Georgia DBHDD, we were a system of care grantee for many, many years. So I love this work, this particular grant. So I feel like I'm among family today. So we're going to move right into our presentation. And Feline and I titled it "It's No Small Matter," because even though children, youth, we consider them sometimes small in stature, they're definitely not to be considered, or their needs should not be considered a small matter. Our children and our youth are very important in so many ways, and it's important that we design and deliver services that are appropriate for them, that are designed for them, that have input from them about what works. So it's really no small matter that the information that we're going to be talking about today. So our objectives for today, number one, which I will be sharing with you, is to gain a robust understanding of the state of and advancement of the 988 Suicide and Crisis Lifeline with a degree of specificity to the resources that are available, and that we've looked at on how to make more appropriate, more accessible, more equitable for youth. And then Dr. Shaw is going to talk to us today about the core principles of the National Guidelines of Child and Youth Behavioral Health Crisis Services, and then to discuss ongoing efforts regarding the improvement of equity in suicide prevention and crisis care through the Black Youth Suicide Prevention Initiative. So again, let's start off with talking about 988.
Hey, Jill.
Yes.
Can you just put it in speaker view so we can see all your pictures?
So what?
But we can't. It's not in speaker view, so it's hard to see the text a little bit.
Okay, it's in speaker view on my screen.
Oh, okay. Well, then if it is, never mind. Just
hold on. Let me just stop sharing and start again. Let's see. Now you see all the slides, right?
I think we're waiting for your screen, Jill.
Yeah, it should be coming up shortly.
I did change it so that we can see the person talking. So we should see most of Jill now. And Jill, thanks for wrangling with your slides. We were seeing the thumbnails, I think.
What do you see now?
We see you now.
Okay, hold on. Let's try one more time. Share window. You see full screen now?
Oh, we see your thumbnail still, but I think if you want to move forward, that's okay too.
What do you see now? Still the thumbnails?
Yeah, we do.
Okay, I can't figure out what to do next, but I'm just gonna go ahead through. I'm so sorry, you all. But if there's anything that I think is really tiny, I will just make sure that I emphasize that for you. So, just a really quick tidbit about SAMHSA and who we are. SAMHSA is the agency within the U.S. Department of HHS that leads public health efforts to advance the behavioral health of the nation and to improve the lives of individuals living with mental and substance use disorders, including children, youth, and their families. And our vision, we envision that people with, affected by, or at risk for mental health and substance use conditions receive the care that they need, that they're able to thrive and achieve well-being. And it makes me smile when I think about children thriving. That just gives me energy. So the SAMHSA priorities. To achieve the mission and vision that SAMHSA identified 5 key priority areas to help better frame our efforts as we address the behavioral health care needs of individuals, communities, and service providers. Yes, we've included you all as well. The SAMHSA strategy is in part driven by the initiatives elevated by the White House, Congress, and HHS. And they're preventing substance use and overdose, enhancing access to suicide prevention and mental health services, which is where the 988 and Behavioral Health Crisis Coordinating Office comes in, promoting resilience and emotional health for children, youth, and families. So children, youth, and families are a definite priority for SAMHSA in our 2023 to 2026 strategic plan, integrating behavioral and physical health care so that there are more opportunities for people to receive whole health care in one setting, strengthening the behavioral health workforce. Those of you who are working in the field, I'm sure definitely this resonates with you and hits home, that there are not enough of us out here doing this work. And then all of this is enveloped by equity, trauma-informed approaches, the recovery approach, and a commitment to data and evidence that is behind all of the work that we do. So the 988 and Behavioral Health Crisis Coordinating Office, we serve as the lead federal organization for 988, and we also serve as the lead federal organization for Behavioral Health Crisis Services Transformation, and we are in the midst of a very large scale initiative that will take all of our help to transform the crisis system across the country. So let's talk a
Jill,
little bit. Yes.
if I'm interrupting you, I'm sorry because the slides are not advancing and I have them pulled up. If you would like me, if you want to stop sharing and I can start sharing, I'm fine if you want to go through this way. I just wanted to offer if it would be helpful because we're not seeing them move.
Okay, let's do that.
Okay, let's share screen. Well, that wasn't very helpful, was it? Do you see your slides?
No, I see the all systems go screen.
Okay. Let's start that again. Dealing with a couple of screens here. I thought I could do this. And it's not working. I'm very sorry. We may have to go back to your screen.
Let me, I tried one more view. Can you guys see that at all? Can folks see slides at all?
Let me X out of mine, and we'll see if yours are up there.
I have to move it back to the intro, but I'm just gonna do the entire screen, and then I'm gonna share.
And then if you can just go to slide 8 when you have them up, Belina.
Yes. Okay. What do
And
you?
I'll just continue from slide
We
8.
What do you
We
see?
can see your slides now. We can see your thumbnails.
The thumbnails. What about this?
Yes.
Perfect.
All right. You gotcha. All right. Need for identity.
All right. Next slide. So let's talk a little bit about the need for 988. There's one death by suicide every 11 minutes. That may be a statistic that several people are familiar with. In 2022, specific to our conversation today, over 950,000 youth ages 12 to 17 attempted suicide. And suicide rates increased from 2021 to 2022 for nearly all populations, and increased by 15.2% for multiracial youth, 12.3% for Asian youth, 12.6% for Latino youth, and 12.2% of Black youth had serious thoughts of suicide. And this is very concerning for us because too many people are experiencing suicidal mental health and or substance use crisis without the support and care that they need. And sadly, we all are aware during the pandemic, this only made a bad situation worse when it comes to mental health and wellness in America. And so there's some urgent realities driving the need for 988 and for crisis service transformation across the country. Next slide, please. And for sake of time, we're going to, Belina, you could just advance past this slide and the next one, and then we'll talk a little bit about how 988 works. And sometimes, you know, we go in spaces like this and we assume that since everybody's in the behavioral health field or touching the field that everyone knows about 988, but we found that that's not always the case. So I'm going to talk just briefly about how 988 works. So let's look at what happens when you contact 988. And Belina, if you could go back one slide. There we go. So 988 is a safe space. It's open 24/7, and people who call can talk about whatever is bothering them or bothering someone that they care about. A lot of people think that you can only call 988 if someone is having suicidal thoughts or is actively in an imminent risk situation, but it's a crisis line, and crisis is defined by the person who's experiencing the crisis, and 988 is available for anyone experiencing any type of crisis. And if you contact 988, trained and caring counselors will listen to you, work to understand how your problem or your loved one's problem is affecting you in that moment, and then move to providing support, working on safety planning, and sharing other resources that can offer additional support. Many people are helped by just the call, the interaction with the 988 counselor alone. But for those who need another level of care, 988 counselors are trained to connect someone to those local resources. Next slide. So there are 5 different options to connect to a caring, trained 988 counselor. If you dial 988 on your phone, if you press 1, that'll connect you to the Veterans Crisis Line. And family members of veterans can also use the press 1 option because we all know that there are some unique needs that families have, and that includes children and youth in veteran or military families, so they can use the press 1 option. The press 2 option will take callers to the Spanish sub network where they can speak with Spanish speaking counselors. The press 3 option And this is an option that's specific for youth who are members of the LGBTQI plus community, and counselors are trained to support youth and young adults in that space. You don't have to use a press option. You can just remain on the line and you will automatically be connected to a counselor who can listen and provide those local support resources. Or you can press 0 to bypass the entire message and get directly connected. So there are lots of options for people who are calling 988. For those who are texting or chatting 988, for LGBTQI plus youth subnetwork, you can now just text the word pride to 988 on your phone, and that will get you connected to a chat with a specially trained counselor. For the Spanish language texting chat, you text the word ayuda, which is help in Spanish, and then you'll be connected by chat to a Spanish speaking counselor, or you can just remain on the text and chat and be connected automatically to a counselor. Then for individuals who are deaf and hard of hearing, for video phone services, you just dial 988 directly on a video phone and you're connected to a crisis counselor who can communicate in ASL. And we're really excited about these efforts to increase accessibility for our special populations. Next slide, please. And again, those special populations, Spanish-speaking callers or texters, youth in the LGBTQI plus community, those who are deaf and hard of hearing and communicate with American Sign Language. And then we're working on culturally competent services for American Indians and Alaska Natives through our tribal network. Next slide, please. And actually, Belina, if you want to skip down to the performance metrics, we can talk briefly about that. More people are getting connected to serve than ever before. And so comparing from 2022 when we launched to 2023, 988 answered 1.4 million more contacts in 2023 than in 2022. And that's a significant increase. The chat answer rate increased from 65% to 94% just in that initial year. Spanish voice answer rate went from 66% to 84%. And in the first year, 988 significantly improved how quickly callers are connected, and the average wait time went from 2 minutes and 39 seconds, and you can lose a significant amount of callers with that long a wait. But we've gone from 2 minutes and 39 seconds to 41 seconds. And I believe now it's just a little less than that. And we're excited that this summer we will actually reach 10 million contacts to 988. And that's just incredible to know that that many people already are aware of the service, trust the service, and are reaching out to get assistance. And Belina, we're going to go on to looking at the vision for the crisis care system. So I mentioned before that our goals in the 988 office are strengthening and expanding the 988 Lifeline, but also transforming America's behavioral health crisis system. And so we're the lead federal agency for that. And what that role entails is identifying and promoting best practices for behavioral health crisis care and disseminating that information to those of you who are working really hard in the field to deliver quality services to our children, youth, and families. And so, of course, we're including a definite focus on equity and providing culturally responsive interventions. It's also to coach partners to support the delivery of crisis best practices. So that is responding when Liz and the Intact reach out to ask if we would come in and be with you all today. It includes activities of our own training and technical assistance center to give coaching and individual assistance on how to improve the delivery of services in the local communities, improving data collection and evaluation, and again, using that data to inform and transform our services. In expanding the crisis workforce. And right now we're looking at interventions across SAMHSA, across the federal government, on how we can all work together to to just let, even at the middle and high school level, just let children understand and know about the behavioral health field and the many options for working and contributing to this field. And then working with our institutions of higher education to transform training programs. I know that when I was in my master's program, we didn't have classes about or specific to crisis care. So we want our higher education institutions to look at adding more classes about suicide prevention, about crisis care, um, so that we can build that knowledge base for people who are entering and coming to work at your facilities and in your practices. And um, just we need more information. So we're working on in inviting people to the workforce and making sure that the workforce is equipped and well trained. And then planning for long-term sustainability. We can't do this work without adequate funding and resources. So doing what we can at the federal level to increase the funding that's available to states, and then helping states to kind of strategically plan how state resources can be used for crisis work, and how braiding and blending of funding can help sustain this work. Next slide. So the pillars for the 988 and crisis care system are someone to talk to. Of course, that's the 988 line, and that was a very important first step. And then right now we're beginning more focus on someone to respond, and those are our mobile crisis, our co-responder units, people who can go to deliver services at the point of need. And then finally, a safe place for help, and these are our crisis stabilization units. And for youth, sometimes that's not necessarily a safe place to go for help, but what services can be wrapped around and provided in a home setting that is more comfortable for youth and their families to receive care. So we're being really creative about what a safe place for help looks like. Next slide, Belina. And let's skip through to that. The Lifeline is proven to work. So in that first year, we've had a lot of opportunity to do research and evaluation, and we know that 988 works. Our research has shown that after speaking with a skilled 988 counselor, most callers are significantly more likely to feel less depressed, less suicidal, less overwhelmed, and much more hopeful. So we know that the line is working, and we're very excited about knowing that when people call, they're getting help. But again, for those who need something else, we also need to work together to make sure that the crisis care continuum is built out adequately in all of our states. So we're working to transform crisis care together. And to truly transform crisis care across the country, it takes the voices and expertise of everyone involved. In the 988 office, we have a monthly session where we just open it up so that we can hear from individuals who are doing this work to inform what we do. We provide updates on those monthly calls, but we take questions and we try our best to answer or follow up with answers, or to build additional training around the information that you all are telling us that you need. And we hold multiple convenings. We have regular webinars and other learning sessions to continuously assess the readiness, refine an integrated roadmap for the crisis continuum, ensure coordination among the implementers and stakeholders in the system. And we all want to align ways to measure progress and success to ensure that 988 and crisis care is designed from the perspective of those who use it. And all of this defines what we call the 988 ecosystem. And it includes those who are working on policy in the government level, and that's the federal, state, and local level government, emergency service and crisis response services. We do a lot of focus on the interoperability between 988 and 911 and first responders, service organizations, and advocacy groups, especially advocacy groups that focus on the needs of children and families, healthcare and behavioral health providers. Again, that's that integrated care, peer and family mentors and community support, and corporate support as well for this work. And as this map shows, we all have to work together to realize this hope for a very integrated, highly accessible, highly equitable system. And let's move, Belina, to talking a little bit about the formative research. I'm mindful of our time. Last summer, we completed our first phase of formative research, and it included 3 key elements to get insights from several populations that have been identified as being at higher risk of and disproportionately impacted by suicide. And so we're looking at those groups. And next slide, please. You'll see our priority audiences are primarily starting with youth, American Indian and Alaska Native youth and young adults, Asian American, Native Hawaiian and Pacific Islander youth and young adults, Black youth and young adults, Hispanic youth and young adults, individuals who have attempted suicide or experienced serious thoughts of suicide during their lifetime, LGBTQI plus youth and adults, people with disabilities. And so these are the priority groups that we looked at in our phase 1 formative research. Belina, and just a little bit about what we found out from this research. We found out some things that why individuals would or would not consider using 988. That's their likes and dislikes about using 988 as a service. And that was very important for us in terms of crafting messaging and getting the word out about 988. And you'll see kind of highlighted on the screen those things that were important for youth, that it's available 24/7, it's free, it's anonymous, it's quick to call or text. The youth said that they wouldn't have to worry about being judged, and they could communicate with someone who was trained to help, a real person who was trained to help them. Next slide, please. But some of the things that they didn't like or that gave them a little pause about calling 988 was opening up to a stranger. And I think we can all maybe relate to that, that the thought that they might not be understood or that their situation might not be understood. There were concerns about privacy and confidentiality, which is really important for youth and being able to open up. The credibility or the lack of credibility for the counselors who are answering the line. Thinking that the responses might be scripted and not personalized, or that law enforcement might be called. And there was high concern among teens that their parents might be called. So next slide. All of these things were taken into consideration across all of the groups, and we're shaping our messaging for that. And what we saw is that the people who were most likely to say they trust, people were more likely to say that they trust and get support from family and friends when they're struggling with their mental health, as well as mental health professionals and organizations. So there is a tendency and a trust in reaching out to you all as well for that information. And we also looked at who are trusted messengers for people who are calling into 988. And largely we saw that friends, their mother, mental health professionals, healthcare providers, and YouTube videos were ways that youth would reach out for mental health information when they were struggling. And we're moving into phase 2 of our formative research, where we're going to talk to those trusted messengers to find out more about what will help to get them the information that they need to help their children, their family members who are struggling, how to get them connected to 988 and what they need to know to also help to advocate for them to get connected to the care that they need. And Belina, if we can skip down to tools and resources, and I'll be wrapping up and turning over to you. There are 2 websites for 988. The first website is for information and promotional materials, and this is for the community at large. And that is 988lifeline.org. And then there's information and promotional materials that you as practitioners can use in your work. You can customize them. give them out to the individuals that you serve to help them know more about 988 and to encourage them to use the service. Next slide. Some of the materials that you'll find in the toolkit, very diverse images and messages. And again, those are downloadable and some are customizable that you can use in your own agency. Next slide. Some examples of 988 messaging in the real world, things you may have seen. 988 has been a question on Jeopardy, and you know that you've kind of reached the pop culture level of importance and priority when you're a question on Jeopardy. Some players in the Super Bowl wore 988 cleats in the game, and that was a wonderful focus. And depending upon where you live, you may see 988 billboards, 988 bus wraps. We're just trying to get the word out in as many ways as we can. And last slide, the 988 SAMHSA Partner Newsletter. You see the QR code there on the screen. If you scan that, you can sign up to get our partner newsletter, and that will that are going on. And things are changing very rapidly. As we learn more information, we're able to develop and provide more resources. And as we provide them, we want to make sure that we get those out to you. So thank you for your time listening. And again, I'll be here at the end if there are questions. And so, Belina, I will turn it over to you.
Thank you, Jill. I'm going to try to turn my camera on. And I apologize for the sniffling and throat clearing during your presentation and ongoing. My allergies decided that they wanted to wait until this presentation to act up today. So now can everybody see my slides? I can't see you, so you can, Jill, or
yes,
okay, we can. Yep.
So I'm going to talk a little bit about the national guidelines for youth crisis care and the direction that we're going in this space. 988 has truly served as a catalyst for crisis system transformation. The National Suicide Prevention Lifeline existed for a couple of decades prior to 988. And on July 16th, 2022, the number essentially changed or fed into that existing infrastructure. However, the most significant piece of this really was the catalyst for driving the creation of developing a no wrong door system for behavioral health. And so the key thing is it has to be a system. And the beauty of this is that, you know, I too was a system of care grantee at a local jurisdiction in the past. And systems of care work is really, I think actually crisis care is catching up to systems of care work. And we really need to stay thinking about how do we not create a program or multiple different programs and put them in a community, but how do we create a system or a network of programs that are interconnected, and individuals who need help are able to receive that help, but then also make sure that they're getting the ongoing prevention, intervention, and post-vention supports that they need. And so Jill laid out the three main components of someone to contact, someone to respond, and a safe place for help of the crisis system. And SAMHSA's vision really is that crisis care can be accessible to anyone, anytime, anywhere. And so that anyone does include youth, and that anyone does also include our racial and ethnic minority individuals, our sexual and gender identity minoritized individuals, our rural and individuals, are persons with intellectual and developmental disabilities, especially those who are youth who get caught in the nexus of multiple complicated systems. And so we want to make sure that we're really creating a system that provides supports for anyone. And so the guidelines that were developed were based upon the National Guidelines for Behavioral Health Crisis Care, the Best Practice Toolkit, as it was called, that was published in 2022. And the QR code is there. And after that, a couple years later, the we at SAMHSA created this set of documents, and the second one being with the support of NASHBID. I had the privilege of being able to review this document on my third day of work here at SAMHSA. And honestly, after reviewing this document, I decided that I made the right choice, that I knew that I was at the right place because the document was comprehensive, and thought about this approach from a systems-based level. It included equity, it included just a really broad degree of considerations. And that broad degree of considerations came from the process and development of what was incorporated therein, and I'll talk about that in a little bit. And I just want to highlight that also on this QR code, or there's the link there as well, at the QR code, you'll see that its companion document, or Safe Place to Be, was one of the white papers that was developed by NASHBID in 2022 by some of the same authors that helped to contractually write our document as well. And we just really believe that they're a beautiful set of companions. And although, as I'll mention in the future, that we are working on building out and developing these guidelines still and revising them, that we will want to include a developmental perspective, including youth in this guidance in a holistic manner, and that this document, although will be actually a core foundational piece of that. Just like we had the adult crisis guidelines that were foundational to the development of the youth guidelines. Also, the systems of care principles are well infused, and I'll talk a little bit more about that over the course of this presentation. The trauma-informed care principles and guidance are really embedded here quite well. Our youth, family, systems, and provider experts and exemplar programs were part of a working group that helped to devise this. So this was not a couple of SAMHSAites sitting together in a room and said, this is how it shall be. But this was a true community voice that came together to provide this input. And all of this is impacted by our desire to see people recover in the way that they desire. The number one priority, as of all of this, is safety. And we do want to make sure that as we're dancing the dance and balancing the dance of safety with home-based autonomy, that we navigate that in a safe way. And for those of you who might be aware, I know that you know there was a lot of questions and push, and actually there were advocates that wrote letters to the government and said, where are the youth crisis guidelines? And you know, some of the delay was trying to make sure that we got it right. Was trying to make sure that we struck the balance of safety and home-based and community-based services, and in making sure that we were not we found that equilibrium in the middle. And so it took some time. It took some time to get it right. And that's really that delay that I know that our stakeholders were really noticing in the field and community. The shared principles between the two guidelines were addressing recovery, the trauma-informed work, the role of peers, the zero suicide or suicide safer care principles, which you can find the information about the zero suicide model more online. Safety and security for not only the people in crisis, but also the staff and individuals who are serving the people in crisis. And then also thinking about how to partner with law enforcement and emergency medical services. But there was this overlay of the systems of care principles that really came out of this document as well. And so I'll go through a couple of them and pair them up a little bit to speed along about how the systems of care principles were really impactful in developing this guidance. And first, the orange ones here, family-driven and youth-guided, are not only essential for care delivery, but being family-driven and youth-guided are essential for the conception, intervention, and implementation and evaluation of services. And we feel strongly about that you know, there's the mantra, nothing about us without us, but that does not just mean in that service delivery, but also having youth and family voice in the administration of programs. I loved and thought that our work with our systems of care grant and our county was quite impactful because we actually had young people on the evaluation team. We strove to have peers in the work that we're doing. And I think that impact was so significant there because it was throughout all of the breadth of the implementation. And then the provision of care in the least restrictive environment and being community-based is at the hallmark. I know that the prior language that you might have heard that Jill alluded to was that there was the someone to call, someone to come to you, and someone and a place to go. A lot of you have heard that as the hallmark of how we were conceptualizing the crisis system. With this work, there were really strong feelings about the use of the word go. And because of that, we have modified the language to a safe place for help, thinking about how do we make sure that we can ensure home and community-based services as much as possible in that framing. And then the collaboration across an interagency network. So, obviously the prior guidance around the adult work focuses on law enforcement partnerships only when necessary. That document is very clear that there's to be law enforcement engagements to be avoided when not necessary. However, in the systems of care principles, we also know that there are multiple other significant systems in which youth are involved, including schools, including, unfortunately, sometimes also juvenile justice, our child welfare systems, our intellectual and developmental disabilities systems, and so they're sometimes not integrated, often not integrated into our mental health systems. And then I would also say that when we talk about that coordination, that also we have to think about the coordination of our mental health and substance use services, and I'll show a tiny bit of data at the end to that effect as well. The culturally and linguistically competent is quite significant because when we think about that and accessibility, these are some of the core concepts of health equity. Although I will get on my quick health equity soapbox, and for the sake of time, I won't get too much in the Black Youth Suicide Prevention Initiative. But I do just also want to remind us that health equity is not synonymous with care. There has been data that has shown that one of the most recent studies that I've seen to this effect is a secret shopper study where a mother was calling for evidence-based trauma treatment to get the care in the clinic. And there was a script that was provided to several mothers of different races, a Caucasian mother, a Hispanic mother, a Latina, and then also a Black mother. When they looked at the data, and there were strong, great clinics. They're not a comprehensive list of clinics. That the white women had the least wait list, or white families. The Latina families had the second longest wait list, and the Black families had the longest wait list. And they were all given a script, so they were all told the same thing. So when we talk about health equity, we just want to make sure that we're making sure that these systems are culturally and linguistically appropriate, and thinking about an anti-racist and an anti-discriminatory standpoint from all of those needs. The Black Youth Suicide Prevention Initiative was really birthed out of data that had shown in 2017 that the rate of Black youth suicide had doubled over the last 14 years. And it really hearkened this Congressional Black Caucus to ring the alarm about this concern, and the Health and Human Services Department, of which we here are a part of at SAMHSA, HHS, developed also a response report, if you will, about some of the work that is to be done. And and out of this, we have now the Black Youth Suicide Prevention Initiative, but there's still work to be done. And this report is from Johns Hopkins, and we have now one of the authors here that's working with us here at SAMHSA on staff. But just to remind us that the work still is to be done, and we're doing that work now. And part of that is going back to this crisis-specific document. Are the core principles we talked about of safety and keeping youth at their homes. But I really want to talk about the number 4 out of an interest of time, and that's really considering family and youth peer support providers and really centering them in this space. When we worked through our systems of care grant, I would want to say that we had well thought through exactly what all of our service delivery options and arrays that we were going to offer were throughout that grant. However, as we just started thinking about what step by step we needed to add, we realized that basically we used the grant to fund youth peer support and youth and family peer support. And I really feel like we in behavioral health need to have a frame shift around the value of peers and for some of us. And I think that some of this comes from the fact that in behavioral health, we have been in a spot in the house of medicine, in healthcare, where we've also often been that step cousin on the totem pole, lowest on the totem pole. And those of us who are also, you think about a lot of us are women who are in this space, or those of us who are racial and ethnic minorities in this space, or those of us who have over time, started just to get a little bit more of a footing in our careers and with age and really worked our way up that totem pole, that sharing power is something that we have to work on. And sharing power with people with lived experience and families with lived experience is essential and vital. And it's something that I think, because we have worked so hard for so long to get to this point, and get our licenses, degrees, that it's sometimes we have to really frame shift in the value and thinking about how do we frame out the scopes of all of these services. So in this document, I mentioned the safe place to be, which is not the safe place for help, that we are using that language now. And I really think I just want the nondescript bricks are just to remind us here in this slide that it can be a facility, but it can also be a home. I use a quick example of a kid who I saw when I was doing youth mobile treatment, who ended up setting a fire and accidentally burning his mom. I was not doing youth mobile response and stabilization per se, but when I was doing this work, I thought it was very important to evaluate what the concern was. And after we did that evaluation, we realized that it was an accident. His mother did get significantly burned, but he was sad and cried every time he saw that. And his mother was also very forgiving, and it was due to some supervision challenges with some parental substance use. But we worked together with this family and kept them out of the hospital. And putting that child in the hospital would have been detrimental when you think about the fact that it was not an intentional fire. We did not just have to jump reflexively and put this child in the hospital, and that this child, taking him away, would really be a sense of additional punishment when the fact that he saw his mother's burned hand every day was enough internalized punishment because of his guilt. So when we think about programs like Youth Mobile Response and Stabilization, which I am not going to go into detail about, and I know that our New Jersey team and innovations it probably has a whole learning management system about it. That this type of ongoing stabilization supports for acute and subacute crises in the community can be really helpful to prevent that. Because we were already wrapped around him, we could keep him out of the hospital. And so I just wanted, this is another statement here about youth peer support and just its value. I think there was a chilling moment when one of the young people that we were working with, she said, "I am hope personified." And that is really what we want to see in families and children or young adults or that are doing this youth peer support specialist work. And so that happened in our grant where we used the youth MRSS model, that we used that young woman was doing that youth peer support as part of the youth mobile response and stabilization model. But also, there is also a model here in Tucson that does have out-of-home care for youth that need it. But I think that we have to have the full array, especially when we think about accessibility, when we think about keeping kids out of detention, law enforcement, hospitals, that we have to have the full array. I'm not going to go into this slide in detail, but you can see that they accept everyone, and they're in the year of this data, I think it was about 2022, they served over 2,000 youth. And a big number of them were also that latency age youth, the 26% in the bottom right, and not just our teenagers that we often think about as well. And then I just also want to go over to that right there, remind us of the substance use disorder comorbidity and why I highlighted that interagency work, especially at the systems level. So coming soon, Jill and I and others in our team at SAMHSA are working greatly on thinking about how do we truly define crisis services and provide concrete, finite definitions of levels of care. And that will feed into some updated national crisis guidelines and guidance. You will be pleased to hear that we do have experts from youth serving systems, including systems of care experts that are involved in this work, as well as a mobile crisis toolkit, which will also be providing that granular implementation information. So we know we just have a couple minutes. I know we had some tech problems. Here is our contact information, and I'm going to pull the slide down so we can see each other.
Thank you so much, Dr. Shaw. There are just a couple of questions that folks were really interested in, and one of them was wanting to know if there were specific statistics on the number or amount of children and youth utilizing the 988 system via phone or text. Is that something we have data around?
Jill?
Yes, we have some data because, as I mentioned before, 988 is anonymous. So callers, texters, and chatters don't have to provide that information, but we do have some self-report data for chat and text. And I'm going to try to share my screen and show you all the two graphics that I have. This first one is self-reported data. Can you all see that graphic?
It's coming.
Okay.
There you go.
Okay. So this is self-report data for text visitors by age, and you'll see for texting, and this is probably not a surprise to anyone, most of the texters are below the age of 25. You'll see that's the highest. And then let me stop sharing that one, and I will also show you text by the numbers for chat. And it's very, very, can you all see that?
There's usually a little bit of a lag. I think we'll see it there. It's coming.
Okay. And similar to text, you'll see that by and large for chat, the individuals who are utilizing the 988 service in that way are our younger, our youth and emerging adults.
Great. One other quick question that I'm seeing here. Are the older numbers, the numbers that folks used to have access to, are they still active, just in case families have some old documents?
That is a great question. Of course, our hope is that eventually 988 will be just as familiar to individuals across the country as 911, and people will know that if there's a behavioral health crisis, 988 is the place to start. However, in most states, those 10-digit numbers that were operating before are still active. In a lot of states, it's the exact same call center, but you can access it in any way. But we didn't want anybody to not be able to utilize a number that they counted on and depended on in the past. And as we increase our communication, eventually states will pull down those 10-digit numbers, but for right now, they're operating parallel in most states.
Oh, that's great. I just want to take a moment to thank you both for being here. As somebody who works on both the 988 TTAC and the NTAC, it's just so great to see these worlds coming together, and we really appreciate your time. I want to let you all know who are still here a couple things. First of all, I did put some resources in the resource folder as folks were talking. So there's the 988 TTAC link. There's a link to SAMHSA's 988 Lifeline. And then I also put the national guidelines in that resource section in case you couldn't use the QR code. So those are there for you.
And Liz, I
Yeah.
also added in the resource section the link to register for our formative research on trusted messengers. That webinar is going to be happening on the 20th. So I put that in the resource section as well.
I'm so glad you said that. Thank you so much. So please go to the resource section and find out ways in which you can stay involved. And then in the Q&A, I put a couple of links for the Black Mental Health Initiative and also some of the prevention initiatives that were mentioned. So lastly, it is just about time, and you have a 30-minute break now, and we are moving into a keynote next at 12:30 Eastern Time, 11:30 Central, 10:30 Mountain, 9:30 Pacific. And Dr. Tanisha Freeman Foster will be exploring the individual, interpersonal, and organizational factors contributing to mental health disparities among Black and Brown youth and young adults. And there will be actionable steps to foster caring and equitable systems in collaboration with communities to eliminate disparities and create meaningful change. Again, Dr. Shaw, Mrs. Mays, thank you so much for being here. Thank you for your time and your ongoing commitment to this very important work. And thank you all for being here. And we look forward to hearing from you at our TA websites. So thank you.
Thank you, guys.
Thank you for having us.
Have a great day.